All right, so I'll give you just an example of propofol because that will give us just a segue here. So propofol, the onset of action is 30 seconds, and some nerd called it arm to brain circulation. A little nerdy. It's trying to like show off, arm to brain circulation. Just the time it takes from circulation from the arm all the way and goes to the heart and then the brain, then you go to sleep. What he's trying to tell you is true, actually. He's telling you that the propofol doesn't take time to put the neurons to sleep. It actually takes time to transport. But once it shows up in the brain, immediately, on that second, everything is asleep. And not only that, probably isoelectric activity. Okay, so and how does that work? So basically, that works based on the 3-compartment model. They call it the 3-compartment model, or zero pharmacokinetics. Okay. So this is the brain. This is the blood, and this is the fat. Okay, so when you give something in the blood, the dose of propofol is 2 to 3 milligram per kilogram IV bolus. Right, so it comes out, let's say, 200 milligram in a 70 kilo man. So you give 200 milligram in the blood, it will go where the blood goes. So what are the 4 organs that has the highest blood supply? Kidney, brain, liver, and heart, right, per gram, right? So it will go there. Out of all of those organs, which one of them has the highest lipid content? Is the brain. So that's why all of that propofol dose, which is supposed to be distributed throughout the whole body, it shows up in the brain in the first 30 seconds. All of it gets sucked in the brain first. And when it goes in the brain, then you don't give any more, because it's a bolus. So this is zero, and then it will start to come out of the brain, by redistribution because of the concentration gradient in about 10 minutes. And as soon as it comes out, then the patient wakes up. So that's why the duration of action of propofol is 10 minutes because it's redistribution. Right? The half-life is different. The half-life is like 6 to 8 hours. Right, because half-life is different than the duration of action. Half-life is the amount of time it takes to drop the serum concentration to half. But the duration of action is the amount of time it takes to wait for the action to finish. Right. So here, most of the medications that work on the brain terminate actions by redistribution, not by the half-life. The half-life affects the infusions and stuff like that. Affects something else, but it's not the actual waking up from a particular dose. When Michael Jackson died, they were discussing in one of the radio shows and stuff like that, saying, "Oh, Michael Jackson," blah, blah, blah. And one of the doctors on the show was saying that, no, I have doubt that the doctor killed Michael Jackson because we found propofol in his blood. So I called it, it's like, You can have propofol in your blood and you can answer calculus 4 questions because the brain is clear now. Anyway, so that's propofol. So whether it's propofol or Versed or anything that we infuse, if you continue to infuse, what's going to happen is that in about, it's going to fill the blood, it's going to equilibrate in about 10 minutes, 30 minutes, depending on the medication between the blood and the brain. And then within about 1 day, it will start to have measurable concentrations in the fat. So you're going to start seeing the propofol now in the fat. Of course, fat is full of fat, right? But it's very low blood supply, so that's why it's going to take a whole day, right? And then within 3 days, you're probably going to have equilibrium between all of the compartments, roughly, okay? Do you know, so obviously this is roughly for most medications, do you know that the FDA with all its might cannot or did not force the drug companies to give us half-lives after infusions? Nobody publishes half-life after infusion, packet insert or anything. They don't care because it's not required. so we don't have anything except one study. One study. In all of those studies were done, actually it's a computer model that actually modeled all of those medications to see what happened after you infuse them continuously for all of this time based on the volume distribution and everything else. This is called the context sensitive half-life. This is basically days of infusion, and this is hours to wake up. So first it looks like this. On the third day or so, just usually accumulate. Ativan looks like this. Fentanyl is the worst we use. Alfentanil is the worst they studied. Alfentanil is the cousin of fentanyl, has like 1/5 of the potency, but it's very fast onset. So it was used here in the United States for a long time, but now it's Europe is mainly using it. Propofol looks like this, accumulates a little bit. And the best medication they studied was remifentanil. And remifentanil is like the shortest acting medication that works on the brain. And it actually it's so fast acting, it doesn't accumulate, even better than propofol. And that's why propofol and remifentanil are the only two medications used in a neuro ICU for sedation, because they want to just turn them off in the patient. Remifentanil, the joke is that you stop the infusion, by the time your hand goes in your pocket, the patient is awake and having pain. Doesn't have tail, doesn't have anything, right? So that's the remifentanil. So here you go. So based on this, that confirms what we know from the zero pharmacokinetics or the three compartment model, and that will create for us 4 different techniques to wean sedation or stop sedation, and we'll do that next time.